Yes, this was a trial known as the Sierra trial, where patients with relapsed or refractory acute myeloid leukemia above the age of 55 who had failed, had either relapsed or failed induction therapy and have a poor prognosis were randomized to receive a high dose of a radioimmunoconjugate, an anti-CD45 antibody linked to radioactive iodine, followed by a non-myeloablative allogeneic transplant, or to conventional chemotherapy to see if the high-dose radioimmunoconjugate could improve their survival. Patients that got conventional chemotherapy, if they failed that, could then cross over and get the high-dose radioimmunoconjugate therapy with the transplant. So in this analysis, we looked at the dose of radiation that they received and whether that impacted their outcome. So the patients got a test dose of the radioimmunoconjugate, and then we measured the dose that they received to their liver, and then that allowed us to then dose their high-dose therapy that they subsequently received so that we didn't cause excess toxicity. We had determined previously that up to 24 gray to the liver could safely be delivered. So in the study, we looked at the patients that got 22 gray or more, or less than 22, and we saw that patients that got a higher dose to the liver had a better response. The administered liver dose, if it was less than 22, 5 of 37 achieved a durable complete remission, and if they got a dose over 22 gray, their remission rate was 28%. We also looked at the marrow to liver ratio, and the patients that had a more favorable ratio had a higher response rate as well. So this was a subset analysis of this trial, which showed a significant benefit in the primary analysis for the use of the high-dose radioimmunoconjugate. And so we think this is a new standard of care for these patients and presents them with a new option for this patient population that have a very poor prognosis.